Okay, and we can let everyone into the waiting room too, if that works for you all. Okay.
Hi, good afternoon, everyone. We'll just give it a couple more seconds here to have some folks enter in. We're almost at 100 participants here, so as people trickle in, we'll do our kind of formal launch here for this session. Okay, we are officially at 3:30 Eastern. My name is Brett Beckerson, as many of you know, because we do this every month. At the National Council, I work with you all, state officials, to understand the CCBHC model and think innovatively about how you can tailor it to your clinics and to the populations that those clinics are working to serve. Today's session will talk about certified community behavioral health clinic state required measures. And with that, we can kind of move to the next slide as I do our disclaimer here. So the presentation was made possible through funding from the Substance Abuse and Mental Health Services Administration, SAMHSA. Its contents are solely the responsibility of the authors and do not necessarily represent the official views, opinions, or policies of SAMHSA or the U.S. Department of Health and Human Services. Next slide. So for this next slide, we're going to have two questions for you all. And we're doing these questions kind of quickly because we want to make sure we can get to all of the great content that SAMHSA is going to be sharing with you all for the remainder of this time. So Janelle, if we could just launch the first question here, and I'll put into the chat. The question is, are you planning to attend NatCon 24 in St. Louis? We are going to have some state-specific sessions there, including some private time for you all to connect with your clinics, to connect with us. So we do also have a discounted rate for state officials, which is $775. If you have questions about that, you can reach out to me. We will get you a state-specific code, but wanting to make sure folks who are definitely coming, likely to come, or just would like more information, that we can get your information here so we can reach out to you all. So right now we've only got about 25% of people in the room who have responded. When we get to that over 50 or hopefully 65%, we'll then share those results. We know that this session or this conference is hard to make for some, but it's in the middle of the country. So hopefully that makes it a little easier for travel purposes. So I think we can end the poll here in a second. Oh yeah, and Jane just added Michelle Obama is going to be a speaker there as well. So in case that's exciting for folks, we'll have her there talking about her connection with behavioral health. I think we can stop the poll and we can share results. So about 22% of you all are very likely to come. 13% are likely, but you want more information. And then about a quarter of you all, you do not know. So we will send information to all of you about that discounted rate and give you all some insights there as well. Last year, we had of the over 5,000, close to 6,000 people, we had several hundred state officials coming. So that's really exciting, not just for CCBHC, but for a lot of other things. So we'll share that. We can go to the next poll. You guys answered that already too. Sorry, I didn't scroll down. And for the in-state meeting, it looks like we got about 40% of you are for the week of June 10th, about 36%. So this is split pretty evenly. So we'll see what we can do for this in-person meeting for this S-TAC effort here. Thank you all again for doing this. And with that, we can go to the agenda. So we are very lucky today to be led through a discussion by Peggy O'Brien and her colleagues around state collected required measures for CCBHC. Normally in this effort, what we would do is we would have you all send me a private message, and I would kind of pause the discussion so we could answer that in real time. For the purposes of this session today, because there's a lot of content to go through, you can send me your questions privately if you'd like to. You can pose them openly to the group, but we will not answer questions until the end of the session. If it's something that maybe we can answer in writing to you via chat, we are happy to do so. But for questions that are asked privately, we will ask those ones openly to the group. So with that, I will pass it over to our friends and colleagues at SAMHSA to walk through this important topic. Thanks so much.
Thank you, Brett. I'm Peggy O'Brien. I am joined by Shweta Palakot, also from SAMHSA CBISC. I want to thank you all for giving us the time to present some information on a group of the updated required state collected measures for the Section 223 demonstration. Today, I'm going to cover the measures related to antidepressant medication management, adherence to antipsychotic medications for individuals with schizophrenia, follow-up care for children prescribed ADHD medications, use of pharmacotherapy for OUD or opioid use disorder, hemoglobin A1C for patients with diabetes, and the patient and youth and family experience of care surveys. The rest of the state collected measures will be covered in February's meeting. Today, I also will go over how the measures that are also in the Medicaid core sets are treated in the CCBHC specifications. I will say up front that there are a lot of measures to cover in 2 meetings, so I will not be going into quite as much detail for you as I did for the clinics. I also recognize that many of you have been working with earlier versions of these measures, but a number of you have not. Therefore, I need to strike a balance in how much detail different people might benefit from. At the end of the discussion, I would love to get feedback either in the chat or aloud as to whether I hit the mark and how we could modify the approach for the February meeting if that is necessary when I cover the remainder of the state collected measures. I also want to address what will be a burning topic before we go any further, and that is where the specs are. The final specification manual, I've been promising it for a long time. I sincerely hope that I'm accurate when I say this, that it will be out very, very shortly. But I wanted to mention that now because I think that it'll alleviate some of the questions that might come in. Next slide, please. So I have my first question. I am representing, and please select no more than 2 of the best answers and respond in the poll. An existing Section 223 demonstration state, a current planning grant state, or a former planning grant state that wasn't selected in 2016, an independent state CCBHC initiative under an approved Medicaid waiver or SPA, any other interested state, territory, or tribal entity, or none of the above. And you can select up to 2. So National Council, if you can just determine how many you've got and let us see it when it's done.
We're almost at 70% here, Peggy. So
Okay.
I think if we get a few more, then we can stop and share the results for folks.
Great.
There we go. Then we can stop and share the results.
Okay. All right. So a substantial portion of you are either an existing state or a current planning grant state or a former planning grant state. A good number are in the state or independent state initiatives. We had about 15% that are none of the above and 17% that are other state territories or tribal entities. Thank you. Next slide, please. So the intended audience for this webinar is existing and prospective CCBHC Section 223 Demonstration State staff, independent state CCBHC personnel, and other interested states or entities. Next slide, please. Okay, this slide shows the measures to be discussed today and then again next month. What I really want to point out here is that all of these measures, except the patient and youth family experience of care measures, are derived directly from the CMS Medicaid adult and/or child core sets, as shown by the asterisks next to the names. As shown by the solid black dots here, nearly all of those as of 2024 are required to be reported by every state Medicaid program. So all child measures and all behavioral health measures. That's most of them. This also means that your Medicaid program is already collecting the data for most of these measures. And on a separate slide, I will point out any very subtle differences that may exist. Lastly, the bold X denotes a measure that is stewarded by the National Committee for Quality Assurance, NCQA. At the end of the stack, you will see statements required by our license with them. The licensing language also will be on the website where the specs will be posted and in the front of the manual itself. Next slide, please. Okay, I want to go through how we approached measures that are already in the Medicaid and CHIP core sets. As I already noted, all of the BHC state-selected measures except the experience of care survey measures came directly from the core sets. States reporting these for CCBHC will already be reporting them in 2024 in aggregate for the state, and most of them will be required of all states. The specs contain the 2023 versions with instructions to use updated versions, including updated value sets, as the core set may revise measure specifications annually. This is important to note. As the core set is updated and as your state modifies its programming for the core set, similar changes should occur for these measures. We made a few very minor changes to the actual specifications that are online for the core set. And those changes take three forms in the specs that you will see. We did strike-throughs for language removed, and I'll talk about examples of these. Brackets for added language, if we substituted some language for a strike-through. And then there are supplemental materials directly before each measure or set of measures. And if you go to the next slide, you can see an example of what the supplemental materials look like. This is just for your information, so you know what to look for. This is in front of each of the measures, or in some cases, sets of measures. Next slide, please. So these are the types of actual changes to the measures that you will see. And I want to assure you that the ones that are actually in the specifications are very minor. We use the word client rather than patient or beneficiary. So you'll see strike-throughs and substitutions there. There were a few measures where we removed age stratifications that are in the core set that were not originally in the NCQA stewarded measures. So there were some where children and adults were grouped together, and some where adults and older adults were grouped together. And I'll give you an example when we get to one. But unlike the core set, we did not ask that you stratify within those because of the small numbers of children and older adults that may be found in many of the clinics. Now, there are measures such as the follow-up for care after emergency department measure that's already separated into child and adult, and we didn't change that. That still exists in that way. So this will get clear, I hope, as I get to some actual examples. We have removed most references directly to the core set. We added stratifications of pair, race, and ethnicity, and that is in the supplemental material. We added FAQs when we have them. That's in the supplemental material that you'll see. And most importantly, there's the requirement that the measure be reported at the CCBHC level for the Section 223 demonstration. And that's in the supplemental material. Next slide, please. So as to the last point, the requirement that these measures be calculated at the CCBHC level, there are a couple of key points I want to highlight from the introductory materials in the specs. Points on the left side of the screen that you see here are the same as they were in the earlier version of the specifications. Attribution as a CCBHC client requires only one visit for CCBHC services during the measurement year. For states, you likely will only have access or may only have access to Medicaid data, but still must stratify by payer because of the PPS and quality bonus programs. So stratification is by either Medicaid beneficiaries, and those include the Title 19 eligible CHIP beneficiaries, versus others, and those include the individuals who are duly enrolled under Medicare and Medicaid and the Title 21 eligible CHIP beneficiaries. And on the right side of the slide, I include a text box that you can see in the specs that quotes directly from the updated certification criteria regarding the need for person and clinic identifiers. So yes, thank you. The last slide before I move on to actual measures. First, some measures have optional exclusions, such as SAA and HBD, and I'll talk more about those. In deciding whether to use an optional exclusion for the CCBHCs, please follow your state's existing practice in reporting for the core set generally. For SAA and HBD, these optional exclusions relate to older people who are frail or seriously ill. So that's an example. For purposes of the Section 223 demonstration quality measure reporting, all required measures must be reported to SAMHSA, regardless of the size of the specified eligible population or denominator for a given measure. Our evaluators will aggregate these at the state level for all reporting, and even then, if the denominators are too small, results will not be publicly reported, and no quality measure results will be reported by us at the CCBHC level. And there's more information on this in the introductory material to the specifications. Next slide, please. Okay, antidepressant medication management has been a required measure since the beginning, and it applies to clients who are 18 or older and is a measure of retention in antidepressant medication management. Now, because this is the first one I'm going to go through today, I'll probably do it in more detail than I will for some of the later measures. So if you get sleepy, just know that it'll be over before too long. Next slide, please. Okay, so AMM measures the percentage of clients who are 18 or older treated with antidepressant medication who had a diagnosis of major depression and who remained on their antidepressant medication treatment for a specific time. And there are two rates. There's the effective acute phase treatment, where it's the percentage of those who remained on the treatment for 12 weeks, and then the continuation phase treatment, which is the percentage who remained on for 6 months. Next slide, please. Okay, AMM can be calculated using either administrative data or EHR data. The electronic specification for fiscal year 2023 is located in the ECQI Resource Center, and the link is in the specs. The administrative specification is in the manual. The measurement period is less than straightforward, and what you see here are really just the basics. I won't bore you by reading it all, but do want to provide a high-level overview because the approach taken here, if not the same, number of days for something, is the same approach that's taken in, I think, the next two measures I'll be talking about. So for the denominator, there are two measurement periods. The first is an index prescription start date, and that's the earliest prescription dispensing date for an antidepressant, where the date is within the intake period, and there's a negative medication history. So below that, you will see the definition of intake period, and you will see a discussion of negative medication history. So all of this is interrelated. And then the measurement period for the numerator, there are two different measurement periods for the numerators, reflecting that one is for a shorter duration of treatment and one is for a longer duration of treatment. And to to just remind people, the measurement period is the period for which data are needed. It's not the period of the measurement year, which is the first one for these measures, as updated, will be 2025, the calendar year. Measurement period may differ from that. So next slide, please. Okay. I am going to go through this one in more detail than I will most of them. I'm going to go through what constitutes the denominator, all clients in the eligible population. So you are looking for people who are 18 or older as of a given date, April 30th of the measurement year, and who are seen at least once at the CCBHC during the measurement year. For each of those people, you then determine the IPSD, the date of the earliest dispensing event for an antidepressant medication during the intake period. You exclude those who didn't have an encounter with a diagnosis of major depression during the given period. You exclude clients who filled a prescription for an antidepressant medication during the 105 days prior to the IPSD on this one. And then you calculate continuous enrollment and Medicaid as specified with, in this case, one allowable gap of up to 45 days, which can't include the IPSD date. So that's more than anybody's ever going to remember. It's all in the specs. It's on the slides. Yes, you will get the slides, I promise. There is stratification of these by payer, race, and ethnicity. And the one important thing I want to note is on these slides that pertain to denominators and numerators, bold means that the specs contain much more detail about how you define things. So for instance, if you were to ask me, how do you determine what is an antidepressant medication? I am not going to answer you with a list of antidepressant medications. I'm going to say, go to the specs and look and see how it is explained there, because that is the source of information for these, and I don't want to be inaccurate too. Next slide, please. So to calculate the numerators, you take the people who are in the denominator at the end, and then you determine those who had a certain number of days or weeks of treatment with an antidepressant medication for a given period, and it differs for the two. And so that, I'm not going to read them to you, but the detail is in the specifications. Okay. Next slide, please. Okay, I did these practice examples for the clinics, and they found them helpful. I don't know if they would be as helpful to you all. They're definitely going to be in the slides. I tried to make them as clear as possible. I will go through a few of them. I'm not going to go through all of them, but I will do this one because this is similar in many ways to the next two. So I'm going to do math here. So we have a CCBHC and it's measurement year 2025, and there are 2,500 people who have received a CCBHC service during the intake period as it's defined in this measure. And for the measurement year of 2025, that's May 1st of 2024 through April 30th of 2025. You subtract those who were not 18 or older as of a given date, and you come up with 2,450. Then for every one of those 2,450, you identify their IPSD, and then you exclude those who filled a prescription in that period right before the IPSD. Then you exclude those who didn't have a diagnosis of major depression during the specified period. And then you exclude those without the continuous enrollment according to the specification, and you come up with 975 in the denominator for this one clinic, and this is all hypothetical. Next slide, please. And here you have the calculations for the two numerators. So you start with the 975 in both cases here. You determine how many stayed in for a total of 12 weeks, and you get 850. And same way with the continuation phase, you'll get 476. And if you could advance the slide, and one more time. Thank you. So there you can see the rates for each of the measures. Okay. Next slide, please. Okay. So adherence to antipsychotic medications for individuals with schizophrenia is for those 18 and older, and it also is retention in medication treatment. Next slide, please. The SAA measure provides a percentage of clients who are 18 or older during the measurement year with schizophrenia or schizoaffective disorder who were dispensed and remained on an antipsychotic medication for at least 80% of their treatment period. Next slide, please. The data source for this is administrative data, and the measurement period is for both the numerator and the denominator is the measurement year. Next slide, please. Okay. So I am not going to go into great detail on this. Once again, for the denominator here, likewise for the numerator on the next slide, the things that are in bold are things that are defined in the specifications that wouldn't fit on the slide and you wouldn't want to read it. I will point out here number 5. This is one of the optional exclusions where you'll want to coordinate with your the part of the Medicaid program that's calculating the core set measures, because this optionally excludes people who are of a certain age with certain conditions, frailty and advanced illness. And so you want to be consistent with the state that you're in. So for programming purposes and just for comparability of data. Next slide, please. Okay, this one also I'm not going to go into detail on. There is a calculation of proportion of days covered for the medication, which is defined in the specs. And the objective ultimately is to get the number of clients whose proportion of days covered is greater than or equal to 80% of their treatment period. And treatment period is defined in the specs. Hey, thank you. And I am I'm going to skip this one. I don't think there's anything I need to point out on here that hasn't been covered. So yeah, thank you. Next slide. All right, so follow-up care for children who are prescribed ADHD medication is for clients 6 through 12, and it is both follow-up and retention in the treatment. Next slide, please. So this is the percentage of children who are newly prescribed ADHD medication with at least 3 follow-up care visits during a 10-month period. One of those has to be within 30 days of the first ADHD medication dispensing. So the first rate is the initiation phase, the percentage of children with a prescription who have 1 follow-up with a practitioner with prescribing authority during that 30-day initiation phase. And then the continuation and maintenance phase is similar but not. So children who were dispensed an ADHD medication who stay on it for at least 210 days, who in addition to the initiation phase had at least 2 follow-up visits with a practitioner, and it doesn't say prescribing practitioner, within 9 months after the initiation phase ended. So if they don't get the visit during the initiation phase, then they automatically are not going to be compliant with the second numerator either. Next slide, please. So the follow-up care for children with ADHD medication is also specified for electronic clinical data system reporting for HEDIS reporting. It is not available at this time, at least in the 2023 specs for the core set, and therefore it is not available for us. Our specs contain the administrative approach, as would the ones that your state has been using for the core set. So by now you should see a pattern for the approach to measure design and measurement periods for these medication-focused treatment continuity measures. As with the ones before, the ADD denominator has 2 measurement periods, the IPSD and the negative medication history review. And similarly, the numerator measurement periods for the 2 rates are distinct. Next slide, please. Okay, here is where I'm going to actually start skipping slides. I have laid out in the slides the steps for calculating both the initiation phase rate 1, and rate 2, the continuation and maintenance phase. And you will get these slides. So I'm going to ask National Council, please skip to slide 34, I think. Yeah, and then go on to, oh my, your slides are slightly numbered different than mine. Skip on down to the next measure, which is use of pharmacotherapy for opioid use disorder. There we go. Okay, thank you. So use of pharmacotherapy for opioid use disorder is new as a required measure for the CCBHC demonstration. It applies to clients who are 18 through 64 years of age at this point, and is a measure of use of medication therapy for OUD. Because it's new to the CCBHC demonstration, I'm going to go through it a little more thoroughly than I have some of the earlier ones. And also, I just want to note that you may see language in the slides that is kind of outdated in terms of what is generally used today regarding substance use disorder. But what I have done is I have adhered to what's in the specifications. So bear with me on that, please. Next slide, please. Okay, so this is the percentage of clients who are 18 through 64 with an opioid use disorder who filled a prescription for or were administered or dispensed an FDA-approved medication for the disorder during the measurement year. And there are 5 rates. There is a total or overall rate that captures, did they receive any medications used in medication treatment of opioid dependence and addiction. And there you see the language I was talking about. That's rate 1. And then there are 4 separate rates representing the following types of FDA-approved drug products: buprenorphine, oral naltrexone, long-acting injectable naltrexone, and methadone. Next slide, please. This is administrative data source, and the measurement period for both the denominator and numerator is the measurement year. Next slide. So the denominator here are all clients in the eligible population, includes clients who are ages 18 to 64 as of January 1st of the measurement year who have at least one CCBHC encounter with a diagnosis of opioid abuse dependence or remission in the primary field or other field, diagnostic field, at any time during the measurement year. You will then calculate from those individuals, those that had continuous enrollment in Medicaid throughout the measurement year, having medical and chemical dependency, including inpatient, residential, and outpatient benefits, with no allowable gap in enrollment for this one. And again, the bold indicates that there is more detail regarding diagnosis in the specifications. Next slide, please. So out of those clients in the denominator, for the numerator, you'll calculate separate rates. And so for rate 1, this is clients with evidence of at least one prescription filled or who were administered or dispensed one of the medications for OUD during the measurement year. This is not the sum of the other rates because people may have been on more than one. It is, did they just get at least one prescription filled or administered, dispensed during the measurement year of any of them. And then you will see the word evidence of, and that's my attempt to paraphrase a very long description of what constitutes knowing whether somebody got a prescription filled or not. So you have to look at the specs. So for the others, they are all evidence of at least one prescription or dispensing, depending upon the medication, at any point during the measurement year. So just one. This is really about access to medication treatment for opioid use disorder. And again, there is more detail in the specs about all of the bolded matter here. Okay, next slide, please. Okay, so I'm just going to go through this. This is the rate 1 denominator and numerator. And so you take the clients who are within the age ranges of 18 to 64 as of the beginning of the year. 2025 in our example. You exclude any who don't have at least one CCBHC encounter that has one of the diagnoses on it during the measurement year, and remove any who did not have continuous enrollment with the appropriate kinds of Medicaid coverage so you can see the services, and with no allowable gap in enrollment. And you end up in my example here with 525 people. And then for rate 1, you remove those clients who do not have evidence of having at least one of the medications, a prescription filled or dispensed or administered during the measurement year. And you end up with 425. Advance, please. And you have a rate here of 81%. Okay, next slide, please. Okay, hemoglobin A1C control for patients with diabetes. This is for clients ages 18 through 75, and it is a measure of ongoing assessment of a critical physical health condition, because CCBHCs are tasked with monitoring certain physical health. Next slide. Okay, this is the percentage of clients who are 18 to 75 who have diabetes, types 1 or 2, and whose hemoglobin A1C was at one of the following levels during the measurement year. So there are 2 rates. The first rate is considered A1C control. And for this purpose, where you've got a population of people who have diabetes, the measure treats less than 8% as controlled. You want to have a higher rate for this one. The second rate is poor control, and the measure treats that as greater than 9%. And you want to have a lower rate for this one. And I'll get into the details of how you do that. Let me see if there's anything else on this slide before we move on. Nope. Next. Yep. Yeah, thank you. Okay, so this measure can use either administrative, hybrid, or EHR data sources. The electronic specification for fiscal year 23 is located in the ECQI Resource Center, and a link is included in the specification. I'm not discussing the hybrid approach, but it is included in the specifications. Hybrid measures are generally being gradually retired. So what I'm going to address today is the administrative approach. The measurement period for the HBD measure denominator is the measurement year, but in my mind, it's actually the measurement year in the year before, because you can use data from the previous year to identify the diabetes diagnosis. So the way the measure is written, if a diabetes diagnosis shows up in either the measurement year or the year before, then they are considered to be suitable for the denominator. The core set identifies the measurement period as the measurement year, but I beg to differ. And then the numerator, the measurement period, is the measurement year. Next slide, please. Okay. There are some details here that I kind of want to go through, but I don't want to go through everything. On number 3, after you've gotten through the age, having an encounter, having continuous enrollment, that's 1 and 2. You want to identify clients with diabetes using approaches that are defined in the specifications involving claims and encounter data and pharmacy data. It's complicated. I'm not going into it here. There are ways to determine it using claims and encounter data or using pharmacy data. You don't have to have it show up in both, but if it shows up in one, then that is satisfactory. And the specs are clear about how to do that. And the diabetes must be evident either in the measurement year or the year before. And then number 4 is a little confusing. You exclude people who don't have a diabetes diagnosis as defined in the specifications, the value set, but who did have a diagnosis of polycystic ovarian syndrome, gestational diabetes, or steroid-induced diabetes in any setting. And I think what this is getting at is they are looking for a more long-term diabetes diagnosis. And I don't know about the polycystic ovarian syndrome, but the gestational diabetes and steroid-induced diabetes seem to be more situational. So I'm guessing there. I don't want to go any further and try to figure it out. You also exclude people who used hospice services or palliative care, and you can optionally exclude those who are over a certain age and frail and have advanced illness. And that's the other example I have today of an optional exclusion that you want to be consistent with your state core set calculations on. So next slide, please. Okay. These are the calculation of numerators, and I'm showing the administrative data calculation. I'm not showing the hybrid calculation. So as I said, the first numerator is for control, so it's less than 8%. If evidence shows that the most recent test, HbA1c, was less than 8%, you comply with the numerator. Non-compliance is if it's greater than or equal to 8%, the results missing, or this test was not performed during the measurement year. You want compliance and you want higher rates. Numerator 2 is poor control, greater than 9%. Numerator compliance exists if evidence shows that the most recent HbA1c was greater than 9%, if the results missing, or if the test was not performed during the measurement year. So in this case, numerator compliance indicates poor control of diabetes. So lower measure rates are better. They're clinically better. And I want to see if there's anything else I want to cover on that. I think that probably is it. Okay, so next slide. Yeah, okay. I'm not going to go through this in detail. I think that when you get the slides, if you have questions, you can follow it along with the specs, and I think it will make sense. I've tried to be really clear in these examples, and I checked my math. Okay, next slide, please. Okay, we're going to have a change of pace here. This is the patient experience of care survey and the youth and family experience of care surveys. These are two different quote unquote measures that address adults on one hand and youth and their families or caregivers on the second hand. And it is an assessment of client experience of care and services, for care and service delivery. Next slide, please. Okay, these have been in place since the beginning, and they use the state's existing annual completion and submission of the MSHIP, or Mental Health Statistics Improvement Program, Adult Consumer Experience of Care Survey, and the Youth and Family Services Survey for Families Experience of Care Survey. Identifying results separately for the CCBHCs and comparison clinics and oversampling those clinics. The specifications go into more detail about that. This is based on data that are collected as part of the state mental health block grants. Next slide, please. So what you should know about this is that the states will continue sampling using the MSHIP and the YSSF for mental health block grants as they do now. But for CCBHC reporting purposes, you disaggregate to capture the CCBHCs individually and a comparison clinic, and you oversample to include 300 clients per clinic. There are no stratification requirements imposed on these by us related to the CCBHC reporting. You report it by attaching the results to the reporting template. And before I forget, the reporting template is going through the PRA, Paperwork Reduction Act process right now with OMB. So I'm hoping that that will be out, and I'll have a webinar at some point on that. And all reporting of results by HHS, including by the demonstration evaluation, will be aggregated back to include all CCBHCs in any given state so that we are not identifying CCBHCs. Next slide, please. Okay. All right, I'm going to briefly go through some upcoming technical assistance that I'm hoping you'll all see. So next slide, please. Okay, On the 15th, we have the second part of this in your next meeting, your regularly scheduled meeting, the state collected required part 2 and optional measures as well. Then on February 22nd, we're going to have office hours for states that the National Council will be hosting. There are a few other things that are going to be scheduled, including, I'm hoping, office hours for clinics, a webinar for clinics about these state collected measures so they get a sense at a much higher level of what it is they're being measured about at the state level. Because it is their data, and then a webinar on reporting template use. Those last two may well be pre-recorded and posted just to get them out there, but at this point I'm still trying to determine how to do that and when. So I think that's all I can say about that at this point. So next slide, please. So now we have a fair amount of time for questions. I think the National Council was worried that I wasn't going to get through these in time. We have time for questions, and during this period, I welcome your thoughts, first of all, on the level of detail and the approach, because if it's unbearable and you think something else would be more beneficial next time, I'm happy to adjust, but please let me know. I also welcome any input from any of you who are already reporting these as to difficulties that you have, that you foresee, solutions that you have come up with as you've done this over the years, to share with others who are embarking on this journey going forward. So I think that's it. And I know that there are questions that have come in, and I'll let Brett take it away.
Sure. Thanks so much, Peggy. Yeah, that was, I feel like I learned quite a bit. And as somebody who is a big fan of the addition around the OUD measure tracking, I think that's really, really cool and going to be super powerful. So yeah, kudos to SAMHSA and thank you for the presentation. Mm-hmm. We have one question come in privately to me, and I don't know if it came in to others, but the question's around data sources, and it says, mm-hmm. Is the data source for these measures being talked about as solely from the CCBHC / the DCO, or are there other sources? I guess there's kind of two questions I see in that. One is are these state measures coming from the clinic? And if they're coming from the clinic, are they also then required, is the clinic then also really required to pull those from the DCO? And is there other sources for those data that the state's looking at to kind of glean those insights?
Yes, let me try and answer that. And it'll become even more apparent next month when I go into the follow-up measures, which are also, these are by and large, except for the experience of care, these are administrative data. So they're claims and encounter data. So it's the Medicaid data that you're going to have access to. You might also have access to data for Medicaid beneficiaries who are dually eligible or enrolled with Medicare. So for the state reported measures, these are reported by the states, and it will be Medicaid data, maybe Medicare data for the duals that you have access to, okay? And then, as I said, next time when we do the follow-up, it'll be more apparent, but there are follow-up measures, for instance, from after emergency department use or after inpatient hospitalization that measure follow-up by the CCBHC 7 days after the hospitalization and then 30 days after the hospitalization. And so only the state really has access to that type of data in any kind of consistent form. And so that's why these measures, the ones you saw today, plus the ones that you will see next month, are considered state collected measures. And because the clinics cannot reliably know if one of their clients has been hospitalized or been in the emergency department quickly, and to be able to get all that follow-up information. So it's state reported. It's not clinic reported, but it's at the clinic level. And that's why the certification criteria say it's really important to have a clinic identifier, so you can identify in the data. And it's also important, if at all possible, to have individual identifiers for people who are served by the CCBHCs. For the measures of follow-up, I would welcome discussion about this from the states that have been doing it, about their DCOs and how they have managed to coordinate the DCO, determine what is the DCO data and use it. Because it's a very good question, because the DCO services are CCBHC services. And so having access to and being able to identify that data is important. So I'll answer it that far. And then if there are more questions about that, and then I would also welcome discussion from others on that.
So to our demonstration states that are, currently on the line, do folks want to kind of share what they've been able to do within that regard? And I also kind of would look to some of the National Council staff. I know that they've been pretty well invested with states, as well as a lot of these kind of data partners, to see where and how they've seen the most success. We have somebody raise their hand, Marin Phillips. Would you want to come off mute? And if it's about this question, feel free, or if it's a separate question, we can add it and then pause and get to it later.
Yeah, I have separate questions, so if I need to wait in line a little bit, that's fine.
Yeah, let's just give it just a moment to see if anybody would want to talk about either where and how they've done that.
Brad,
Well,
if nobody wants to talk, we can come back to it, but go ahead.
Well, no, yeah, it does seem like we've got some quiet students here today, but we've seen with some states, when they're using population health management systems that are built into the cost of the PPS, they can also include that with their shared partnerships with DCOs, and that helps to have a one location for those data from both the DCO and the CCBHC that then gets sent upward to the state. So we have seen some success with those kinds of partnerships. I'd recently sent around some of the data from Missouri, and I know that those Missouri clinics have a lot of DCO partners, and they all use the same population health management system that helps to kind of make that much more clear when capturing those data. So that could be something that could be helpful there. And Marin, now, thanks for being so patient. We can hear your question here.
Okay, I have two questions, if it's all right, since I've got airtime with Peggy. This is Marin from Minnesota. My first question, I'm asking on behalf of the team that calculates these state measures for all of our Medicaid programs at Minnesota. They were asking if you could explain a little bit more about how the specs differ from the core set. Are these kind of umbrella changes that apply generally to the CCBHC program? Are they things that are going to need to be updated yearly and might affect the value sets? They're just curious to know how they need to adapt, how they calculate rates for CCBHC.
Okay, for the CCBHCs, first of all, very simply, it's going to be requiring just to separate out the CCBHCs and make sure that you have attribution of people that go to them. But other than that, I kind of really went through the whole laundry list of types of changes. Some of them are so minor they're things like not calling them beneficiaries, because we're not talking about beneficiaries. Adding in the supplemental material the stratifications, changing, removing the age stratifications, like for instance, the HBD measure of A1C. The way it's stratified in the original NCQA measure is, I think, is just like we have it. The Medicaid core set separates out the people who are under 65 and those who are over 65. We put them back together because many clinics will not have enough people between the ages of 65 and 75 to be able to get a decent denominator for a rate. So that is the only, those are really the only kinds of things that we have done. The value sets will be the same value sets that are used for the core set. I did mention that each year as the core set gets updated, which happens, sometimes those changes are major, sometimes they're minor. If it's the same measure, we're not talking about different measures, but the same measure, and there are updates that are made for the CMS core set, then the CCBHCs would be expected to follow along with that. So I hope that answers your question, but please restate it if I didn't get to the core point.
That's perfect. That's what they were asking. They were just kind of frantic, like, how much extra work is it going to be to code? But they've already been doing more advanced stratification when they produce rates for us anyway. So I don't think it'll be much of a change. But then my second question is, what would be the possibility of adding other services that aren't currently in the value sets for some of these measures? So I'm thinking about the follow-up measures, so this might be more applicable to next time, but adding things like peer services or targeted case management or CTSS.
Mm-hmm. We have, I see a heart there, and I understand why you would love to do that. We had to negotiate quite a license agreement with the steward of most of these core measures, and we are kind of prohibited from changing them. And what we have been allowed to use is the measures that the core set's using. So each year the core set will be updated, and hopefully the changes that you're interested in would be sooner rather than later, but we cannot affect those. And actually, if there is a consensus that there are important changes that need to be made to the measures, the steward of the measures, the originator of the measures, is the place to go.
Okay, thank you so much.
Mm-hmm.
So just to kind of put a or just a clarification here, Peggy, too. States can collect other measures, or they can pull in other data. Just SAMHSA is not going to be requiring those data from outside of what you've walked through, correct?
Right. And if you do collect other data, we need to, you don't need to send it to us. And if you want to send it to us, we just need to know what the rates are for the way we we specified it, so we can compare across states.
Sure, absolutely. Other questions from other states that are here, feel free to put them into the chat or just come off mute. We did get a private message here. Let me just see if I can. For the surveys, will the specifications provide the logic on how to calculate each of the response categories?
The specifications for these are fairly short, and they're actually in the version that is posted on our website right now. We still have the preliminary version of the specs up. You can look at it. What we have is we have a link to the current survey, and you will be able to see what is asked. It's only certain portions of that survey. It's the parts about experience of care. Your state is hopefully has been for a long time collecting this data for the mental health block grants. So one thing that you do have to do is you do have to work with your behavioral health agency, the mental health, depending on how your state's organized, and make sure that you can access this for the CCBHCs. And that is something that I think would be also fruitful for existing demonstration states to talk about, if they've had problems with this, how they've handled it, and any solutions that they might have. So I'm happy to hear from people about that too.
That's great. We have a follow-up question here around it. Can you define Medicaid enrollment and allowable gaps? Is it simply if there were Medicaid, is it simply if they were Medicaid eligible on a particular day or month, if a state has a monthly verification?
Okay. The people that are calculating your Medicaid core sets have been doing this for a very, very long time. It is clearly spelled out in each specification what the requirements are for continuous enrollment, and it means enrollment. I'll say enrollment instead of eligibility. Were they enrolled in Medicaid on for the entire year? Sometimes they will allow a gap. Each measure that has this kind of requirement is really clear. Is there a gap allowed in it, and how long? They have things called anchor dates, which is a date when the person had to have coverage, Medicaid coverage. So if you have an allowable gap, the anchor date cannot be in that period where the gap was. And each one that does this has clear requirements in the specifications, and the Medicaid core people in your state are very familiar with how to do this, and that is something that if you need to talk to them, or I'm happy to talk to people on office hours more about this. The other thing I was going to mention too is that CMS Medicaid has TA also related to the core set online. I was going to go on and get the links to that beforehand, but I didn't get around to it. But if anything I have told you is unclear, then there's another source out there that can also explain it to you. So that's my answer to that.
That's fantastic, Peggy. And if you want to send us those links, we can send it out to everybody here so that they can have those resources, as well as the slide deck and the recording of this presentation here as well.
Okay.
Any other questions before we do one? I think we have one more poll question for the group here. But any other questions for Peggy, or Peggy, any other thoughts that you want to share? Yeah,
I just wanted to see, is this too much detail? Is this not enough? What works or doesn't work? Any thoughts? Just put it in the chat, please, and we'll look at it for next time.
Yeah, and if people want to kind of share their thoughts, ideas, feedback candidly, feel free to message me privately. I'll keep your secrets. I promise. And then we have this additional poll here. So in the last 90 minutes, I've learned, and then kind of add this in here as well. So we'll hopefully get over 60% of people responding, and then we'll share those results. Okay. And Peggy, you've got some praise from Liz Rumillard in Maine, who is a pretty impressive state official, if I do say so. She's been doing some really cool work on CCBHC up there in New England.
Thank you. Thanks.
Some feedback we've got is somebody sent privately, it's the right amount of information until we get to the actual technical specs. So maybe a bit more detail, or we can kind of think to how to rework some of that.
Okay.
And here we've got about 90+% of people found some useful information or a lot of useful information. So I know I'm definitely in that 90%, so that's really helpful. Great.
Okay, super.
And then one more question I think we have for from Jane here too. if we can ask that question before folks drop off. Jane, do you want to unmute and ask your question, and then people can add it into the poll?
Yeah, thanks, Brett. Just real quick here, we were planning to do a webinar about how to build your quality measures program. We were going to do it during the monthly state meetings, but we are so fortunate to have Peggy here to give you information about the specs themselves. So we just real quick wanted to ask, if we do, when we do this webinar, would it be important for you, and I think you can go ahead and pull up the poll so you can see, is it important to you that it happens sometime before the demonstration applications are due? Would it make sense to wait for that sort of gap in between? You've sent in your application and you don't know yet if you're in the demo, or is it something that at least planning grant states would really want to know that they're in the demo before they start building that information? So I see that people are starting to answer, or basically just, we couldn't quite decide. And I imagine it depends a bit on what type of state you are. But oh dear, I'm seeing the numbers come in, and most people want it before March 31st. Now I wish I hadn't asked. No, I'm just kidding. But we didn't want to sort of crowd Peggy's trainings too much during the monthly state meetings, but thought it might be something that you would need. So looks like about 45% of people have responded. And I'm seeing about 60% want to have it before the demo apps are due. So we will do our best to try to get that all put together and advertised to you so that you can sign up for it. All right, so I think I got what I needed. Thank you.
Thanks so much, Jane. For folks, any final questions or things for Peggy or for our team? It can be related to quality measurement, or if you have a broader question, you can obviously email it to National Council, or you can ask it here aloud.
You can also use the SAMHSA email box where we take questions too.
And they are very speedy with their responses. We've had some really interesting questions come in, sent it, and I know we've got a lot of grateful state officials with those responses they've received.
We try.
Well, if there's no questions from folks, I'm going to be reaching out to the states that engage in this collaborative to see if you would like to have some one-on-one time with our experts, Jane, Dorn, Becca, others, and then see if we can do that, because we know that with the application coming up, there's a lot of burning questions or kind of back burner ideas and questions that you all want to think through. So I will be reaching out to you all, or if you'd like to be proactive, reach out to me. I know a few states have gotten those emails from us today. So without any final thoughts, Peggy, on this, just want to make sure you get as much airtime here as we can give you.
No, I will say though that for people who felt that the amount of detail was not sufficient, if you have specific questions, there are two ways that we can address it. One is you can send questions in the email box, or we are going to have the state office hours on the 22nd of February. If you haven't gotten it answered somehow by then, I would just love to see the questions in advance, because I can give more intelligent answers if I know what I'm talking about. So that's all I have to say.
Great. Well, for folks who want to email the SAMHSA inbox, I'm putting it into the chat here so you all can see it. We'll also include it in the email we send out, and it's here. Oh, the more specific email address. Thanks. Yeah, any ideas, questions, thoughts, feel free to email us. But if not, you all get about 20 minutes back at the end of your Thursday. So have a great rest of your day. Have a great weekend, and we will talk to you all soon. Bye-bye.
Thank you.